Just introduced myself. Let's see, is Google Hangouts is sharing screen.
Yeah, you can just press hide.
Dr. Bradley, I'm one of the neurologists here. I mostly work with epilepsy, and I'm sort of behind some of the scheduling for the physiology section. And today we get to discuss central visual pathways. This is a sort of an introductory type lecture because there's more detail on some of the physiology of these pathways in later lectures, just to give more of an anatomic background for the pathways involved. So central pathways that are actually involved with processing vision, basically you start at the eyes and go backwards along the tracts. There's the optic nerve, the nerves join at the chiasm, and then the tracts extend backwards from there. This sort of structure clinically is pretty useful because we can tell whether something's coming from the eye, the chiasm, or the cortex, mostly by the deficits we see on exam. Then the tracts go back into the thalamus, the lateral geniculate nucleus, and then they radiate sort of outwards, a little bit medially, and back into the occipital cortex. The primary visual cortex, also known as the callicrine cortex, is back in the occipital pole. It's the V2 or V1 area, and then there's additional visual association areas nearby, V2 through V4. There's also pathways to the hypothalamus, the pretectum, and superior colliculi. The pretectum and the superior colliculi are in the brainstem, in the midbrain. This is sort of a diagrammatic representation of what I just tried to describe. This being I guess that would be the right eye, and you can see the projections from the lateral retina going out the back. That's right. And this is pretectum right here. Right here's the superior colliculi, and this one is the lateral geniculate nucleus. Radiations go back this way. This is kind of important because oftentimes in temporal lobe strokes, you'll involve this particular, I think it's radiation. So you can see some partial blindness. Usually it's the lower quadrant. Pupillary light reflex is sort of diagrammed here. We've got light stimulating the eye. It goes back along the pathway and goes back to the geniculate nucleus and the colliculi. And these are involved with the reflex to accommodate the eyes. Okay. Recombination of vision. Now, when you actually analyze vision, input is inverted onto the retina, and that's done by the lens. So this is sort of the same way a telescope works, in that a telescope also inverts the picture in both vertically and horizontally. Temporal fields tend to project onto the medial retina, and lateral fields tend to project. Temporal fields project, as the signal goes down to the chiasm, the temporal information actually crosses over, and so the lateral fields cross over. Nasal information stays ipsilateral. And so it'll be on the same side of the brain as the actual stimulus. And the combination combines information from right and left visual fields into the visual columns. Those are found in the primary visual cortex. Okay. Now, because of this arrangement, everything is kind of on the back of the brain is inverted and flipped. So the left or the right visual field will actually project to the left cortex and vice versa. And I guess I've got to correct that typo up there. Okay, so this is the way of diagramming what's actually happening with vision in the eye. You've got something you're looking at. This thing is flipped and inverted on the back of the field, and when you look at the actual visual fields for each eye, this is how they're reconstructed, with left monocular vision and right monocular vision looking at that field right there. retina, as you notice, everything has been inverted and flipped. These are the fields, but this is actually what's projecting onto the retina. Okay. And this is trying to show the binocular differentiation here. When you have images that are separated out through space, you get a differential representation, different sort of localization on each eye, and that is recombined by the brain to generate a binocular field. It takes input from both eyes. If you're only using one eye, you don't really have the capacity, most people don't have the capacity to have any binocular stereoscopic vision, or with just one eye. Now, people, having seen a lot of these patients with loss of one eye, they do learn to accommodate. I think it's mostly on the basis of size of images, but they can't tell in 3 dimensions the way people with binocular vision can. This is the callicrine cortex, and there are, I guess, a couple components to this. The macula is right in the middle. You've got a binocular portion, which is where you have this gradation and mixing of signals, and then sort of exterior to that, towards the back, is where it's more monocular, and that's where your vision is not as well defined. It's an infrequent target for stroke, which is a fortunate thing, but it's also probably the most common thing to miss on a routine exam in the emergency room, because a quadrant anopsia or hemianopsia is not usually recognized by the patient, and it takes a sort of a focal effort on the part of the physicians to really figure out, hey, there's a field cut going on. Vertical information is passed in through the optic radiation, sweeps back from the lateral geniculate nucleus into the cortex. Superior visual field is actually in the inferior visual cortex. The inferior visual field is in the superior. And the fovea ends up at the caudal tip of the visual cortex. And it's disproportionate, so the actual fovea is highly represented in the cortex, which makes sense. That's where you interpret most of your data. Here's a representation of the fibers coming out from the lateral geniculate nucleus, and Meyer's loop is the one that goes out into the temporal lobe. These are inferior, so sometimes you'll lose the superior field with this type of a stroke. If you have a stroke in this general area, you might have more of a loss of inferior vision.
What about the fovea?
The fovea, I think it's kind of, got lack of mouse here, it's kind of buried right in there, I think. Okay, fields as a diagnostic. So preservation of organized maps, and this almost goes back to my days as a mathematician. So what you have is a map that takes a space, puts it into a pattern on the surface, which is your brain. And it is continuous. It has lots of nice little mathematical properties if you want to analyze it like that. But practically, it means that there's a one-to-one correspondence, and it's easy to try to interpret some of the data. If you can analyze the actual fields independently, it gives you a great deal of information about what's happening at the surface, because that's where they are represented. So fields in one eye implies a problem in the anterior to the chiasm. What do I mean by that? If you've lost all vision or partial vision, but only in one eye, the only way to really explain that is something affecting the optic nerve coming out of that eye or the eye itself. After the chiasm, things are switched and combined, so you would expect things to affect both eyes, but one side, or potentially both sides. Bitemporal loss, when you lose the lateral, you have some pressure on the chiasm. The significance of this one is that the chiasm is very close to the pituitary gland, and so pituitary macroadenomas, the larger ones, it's not uncommon to present with bilateral vision loss laterally. Homonymous hemianopsia implies optic tract, full radiation over one visual cortex, so basically it's back in the brain. And then superior quadrant implies Meyer's loop loss, or something affecting Meyer's loop. Okay, so again, this shows some of the radiations. Here's Meyer's loop, and that shows superior loss. This is where where you have an infarct of the caliprine cortex directly. It will typically take out a hemifield, and that will be the deficit.
I think it's a very easy way to remember, right? Your inferior fibers in the retina remain inferior in your brain, so if it's opposite to that, then whenever we see lesions in the brain, it always be the opposite, like feel, like superior. I think that's a very good way to remember that.
Yep. Okay, we talked about a chiasm lesion. Again, it tends to be lateral visual fields that are taken out. And if you had something impeding or affecting the optic nerve, you lose vision in that affected eye. Okay, so functional maps. Within the cortex, there's columns set up for inputs from each eye from the same point in the visual field. So again, the cortex is set up by fields, and so you'll get things from both eyes because they both contain that point in the field. Columns are for vertical orientation. There's columns as well for vertical orientation, which picks up edges. So if you're looking at an image and there's a stimulus or a line in the image, then that will be picked up by the columns that are sort of parallel in the visual fields, the visual cortex, excuse me. And some areas are tuned to direction of motion, to the right or to the left. Again, as you sweep across columns, the interconnection of these cortical structures probably give you the clues that there's some direction of motion. Okay. So this was one experiment that's actually in, I guess, the textbook, right, that we're using this year. There was some simulation, and there's a orientation at which a light bar stimulus will fire off particular neurons in the caliprine cortex, and so they have a predisposition to registering stimuli in a particular orientation. And for this one, it happens to be a vertical orientation, stimulates the neuron that happens to be recorded at that moment. If you put it somewhere else in the cortex, you would see a different pattern. Okay, and what was this about? So this is, I think, to show some of the tracking when you have things moving across the field. You change the signal across different columns. Okay. Again, vertical orientation versus horizontal orientation changes again which columns are involved, and you can sort of track that right there. Okay. So these were just visual images showing different orientation for stimuli. This is actually the original picture, and then these are the pictures as perceived by different angles skew in the cortex. So if you looked with all the neurons with, let's see, where's the angle? With this orientation, you see this pattern, kind of a picture, and when you look with a sort of a perpendicular orientation, you will see a different picture. Now these are combined by the brain to generate sort of the original picture, but it's a combination of these orientations and the stimuli and the different patterns that eventually get sort of combined into the final picture. Just sort of looking at this kind of leads me to wonder if there's any component of, some striation type differential flow with migraine, because that would be kind of what a migraine aura would look like. This is a thought. But okay, lateral geniculate nucleus is organized by side of input, so there's still a right and left eye input into each part of the lateral geniculate nucleus, and then the output layers are, I think they start to fuse at that point. The outer layers are the parvocellular layers, the smaller fields, they sustain impulse. So if you stimulate, you'll get a continuous signal. It doesn't attenuate so much. Color is also represented in the parvocellular layer of the lateral geniculate nucleus. There we go. The inner layers are the magnocellular layers, and they're more black and white. They attenuate quickly, and they have larger fields, so they're not as fine-grained. Conicellular layers are in between and provide fine color, and they tend to involve get the projections from the short wavelength cones from the retina. Okay, interpretation of vision. So there's some geometrically simplified arrangements, which we sort of alluded to in terms of some of the signals that are processing through, in terms of orientation, in terms of moving across the field. It does maintain the relative orientation, so if something is to the right of something else, you preserve that in the visual field. There are many different modes of information that are being interpreted. You've got basically light, color, you've got edges and direction, and you've got movement as well, in addition to sort of a static direction. And then they recombine to sort of what we think of as vision, and maybe there's some variability as to what that actually is from person to person. Where'd she go? Lakshmi's gone.
Lakshmi, she went to the bathroom.
Oh, it's okay. It's all right. I was just wondering if she had any thought on that. Okay, what the end result is, you incorporate all the data from in the visual cortex, and this gives you your picture of the world, or a visual representation of the world. Now, there's a couple of things to say about that last little point here, because as having treated strokes, when you lack the interpretation of the cortex, it's not quite the same as a sensory stroke or a motor stroke, in that you don't know you're missing it. The whole interpretation is gone, and it's just a gap. So if there's cortical blindness or partial cortical blindness, patients, this is why it's often missed in the emergency room, they don't know anything's wrong. But when you analyze what they can actually see and how they see it, there's a gap. So it's useful clinically. It also indicates that it's kind of a self-contained awareness and representation in the same place. I think that's it. Yeah. It's a very short talk. Lakshmi, come back here?
No.
Any
She was
questions?
running, so I think she might be.
Oh, it's okay. It's okay. Any questions? No? You guys cover this in